ম্যাকলেডের কোন ডিভিশনটা আমাদের এখন করতে নিয়ে অরুণাচল জানি না, ইনিশিয়েটিভ নিয়েছিল অপূর্ব মুখার্জি আর্থিক করার
Yeah.
Well, hello, everybody. My name is Michael Weber. I'm professor of medicine at the medical school at the State University of New York, the so-called Downstate Medical College in New York City. My main interests are in hypertension. I'm a member of the cardiology division at my medical school and at the hospital. But for many years now, I've focused on high blood pressure, on the public health aspects of high blood pressure, on the clinical aspects, and even some of the basic science work. I've been particularly interested in ambulatory blood pressure monitoring and different ways of measuring the blood pressure, and very much involved in clinical trials with outcomes events, looking to see which treatments and very importantly now, which blood pressures are best associated with optimizing outcomes in hypertension. These are things I'll be talking about very soon, but let me say again what a pleasure it is to join you for our discussions today.
Good evening, Dr. Weber, Dr. Hiramat, and all who are listening to us here. I am Dr. Anjanlal Datta. I'm from Kolkata, India. I'm honorary professor in Department of Cardiology, Vivekananda Institute of Medical Science. Basically an interventional cardiologist and fellow of the Cardiological Society of India. Though my interest is primarily on interventional cardiology, but in clinical cardiology I'm interested in hypertension and heart failure and ischemic heart disease. That's all. I look forward to participating in academic activities as much as possible.
Hello, everybody. I'm Dr. Shirish. Dr. Weber, I'm in Pune, 2 hours drive away, and I'm the director of Cath Lab at the Ruby Hall Clinic. We are a very popular intervention center in this part of the country. I incidentally happen to be the president of the Cardiological Society of India, which is a big organization, one of the largest in the country. And we do collaborate a lot with ACC, AHA, and especially the European Society of Cardiology on many aspects, which includes hypertension, of course. So we are very eagerly and expectantly looking forward to your inputs, Dr. Weber, this evening. Dr. Weber, I guess you can start.
Okay, thank you, Suresh. And let me just say in passing that I've been to Pune a couple of times, and it is a 2-hour drive and a somewhat hair-raising 2-hour drive. You have to be a brave man to do that trip. All right. I'm hoping you can see this title slide of mine, and that we're ready to go with our discussion. So I will talk. You can see it?
Very well, yes.
Yeah,
Good, excellent, excellent. So I want to talk about a couple of unresolved issues in hypertension, some of the questions that are occupying our thoughts at the moment, particularly bearing in mind that in only a few weeks from now, about 6 or 7 weeks, at the American Heart Association meetings in California, early in November, they will be announcing the new hypertension guidelines for the United States. And I'll be talking about some of the issues in those guidelines as we go through this brief discussion, because there's no question the way we deal with hypertension is going to change, at least for many of our patients. Well, I'm having a little difficulty here advancing my slides. So, oh, here we go. Let me, first of all, put up a short list of some of the issues in hypertension that we are debating at the present time. First of all, what is the best target blood pressure for treatment? Should it be the old-fashioned 140 or 130, 120? We know there's been a lot of research lately. Let's see if we can focus in on where that's going to take us. Hypertension in the young. What can we advise about that? And I feel very strongly, because I know not only here in the United States, but very much in India, I'm told, physicians are finding a great deal of high blood pressure in young people, young adults, people in their 20s, 30s, and 40s, people who've not typically been included in clinical trials. So what do we do about them? What sort of criteria can we apply to younger adults? Because we all believe that the sooner we start treatment, the sooner we change things, the better the long-term prognosis. Another hot topic is treatment-resistant hypertension. Why is it that so many patients, maybe 20%, maybe even more than that, don't get their blood pressure well controlled? Now, that could be all sorts of good reasons, and we'll talk about some of those reasons, but it is, again, a hot topic. And finally, I want to briefly talk about the angiotensin receptor blockers, which I believe have now emerged as the core therapy, the usual starting drugs for most people with hypertension. Not just here, but I think, again, very much so in India. Well, you don't need me sitting here in New York to tell you about the main causes of death in India. I think that the fact that I'm accompanied today by 2 interventionalists in the realm of cardiology, that ischemic heart disease is very, very much a huge issue for you in India. And stroke is not that far behind. So 2 of the major consequences of hypertension are very much at the top of the list in India. And even further down on the list, we see hypertensive heart disease, which I assume pertains to heart failure, which is a rapidly growing diagnosis as well. We've all heard that the World Health Organization, the WHO, has now designated hypertension as the world's leading cause of premature death and disability. For the first time ever, a non-infectious disease, a non-communicable disease, is listed as #1. So what about establishing treatment targets for blood pressure? What do we know? Well, here's a study that I was a small part of, published in The Lancet about 10 years ago, where we asked the question, is it important to be better in terms of getting the blood pressure under control as opposed to not better? And here, in a preliminary way, we see that if we just look at a whole to the specific, we see that cardiovascular events, stroke, both in the blood pressure trials, where we look at different levels of blood pressure, or cohort studies, all show a strong benefit for treatment as compared with placebo. This I'm showing you now, the so-called systolic hypertension in the elderly program, SHEP it's called, was done 25 years ago, in fact published 25 years ago, which means it was done even more than 25 years ago. And it asked the question, at that time, a very question, should older people, and they defined older people as more than 60, now I think we'd probably use a cut point of 65 or even 70, but anyway, they use 60, and asked the question, should we be interested in older people who just have systolic hypertension or predominant systolic hypertension? And we can, with placebo treatment, they happen to use the diuretic chlorthalidone, reduced strokes by 36%. And it also, by the way, reduced myocardial infarction by about 36%. So a dramatic demonstration that just thinking about systolic blood pressure is perhaps the best way of understanding hypertension. These days, everybody is talking systolic blood pressure. All the guidelines will focus almost entirely blood pressure. This is the work that I had mentioned earlier. This is something we published in the Lancet about 10 years ago, asking the question, is it worthwhile pushing the blood pressure down to less than 140 as opposed to allowing it to remain above 140? And we can see the answer is a very strong yes. A composite of cardiac events, if you can get the pressure below 140, is reduced by about 25%. Stroke is reduced by better than 40%. Mortality, death from any cause, is reduced by better than 20%. Myocardial infarction, not quite as strong as some of the other findings, but nevertheless heading in the right direction. And hospitalization for heart failure, again, dramatically improved. So now we can do a relatively new study published just last year, a meta-analysis. Now, normally I don't like meta-analyses because they're made up of all sorts of studies, come from all sorts of backgrounds, and in the end, you're never quite sure whether it's appropriate to pool all of these studies together. Now, this is what you might call a mega meta-analysis, because they used 123 studies. That's enormous, with a total of over 600,000 patients. And what they found, it didn't matter what blood pressure medicines you were using. In fact, sometimes the blood pressure medicines were being used for non-hypertension purposes. But by measuring blood pressure before and after the treatment, and by carefully evaluating whether patients had major outcomes, they reached the conclusion that for every 10 millimeters of mercury reduction in systolic pressure, even starting as low as around 130, there was a big reduction in major cardiovascular events, in coronary heart disease, about a 17% reduction in coronary events, about a 27% reduction in stroke, about a 27 or 28% reduction in heart failure, and very importantly, a 13% reduction in all-cause mortality. So a huge benefit by being aggressive. I don't want to say more because I think obviously a meta-analysis should not be overinterpreted, but this study, also published in the Lancet, got a great deal of attention. Now, people say, well, what about people with diabetes? Because diabetes is now so common, particularly type 2 diabetes, which I understand is basically becoming an epidemic in India. Does diabetes have a different target blood pressure? We've been looking and seeing maybe 140, 130 in people in general with hypertension. What about diabetes? Well, this was a study that looked at it very carefully. the Accord trial looked at whether being super aggressive, getting the systolic down to 120, was better than the usual getting it down to 140 in people with diabetes. And the answer was, if you look at the primary outcome of that trial, which was non-fatal MI, non-fatal stroke, or cardiovascular death, the typical triad of cardiovascular outcomes that we tend to measure in cardiovascular trials, there was about a 10% reduction, and it was not quite statistically significant. A bit disappointing. But if you look at non-fatal stroke, there it turns out, if you look at just stroke by itself, there was a 40% reduction when you push the pressure down to 120 rather than 140. So that was a very interesting signal. And now going back into this study with some post hoc analyses, I think they've reached a conclusion that somewhere around 130 seems to be a very optimal target in diabetes. Well, let's look at the study that's sort of revolutionizing, or at least changing, hypertension in a pretty big way, the SPRINT trial, a study, again, focused on systolic blood pressure, and again asking the same question we were just talking about in the diabetic patients: is 120 better than 140? And in this particular trial, which excluded people with diabetes because they'd already been dealt with in the Accord study, we're now looking at intensive treatment, shooting for 120. They got to about 121, versus standard, where they finished up at around 136. And there was, you can see, a 25% reduction in the major outcome, which was basically a composite of several cardiovascular events, which is shown on this slide. So again, if we look at the primary outcome, and remember we're comparing intensive treatment around 120 with standard treatment less than 140, we see a 25% reduction in overall events. And now all of these events listed underneath the primary outcome are in fact what made up the primary outcome. They all contributed to it. So you can see myocardial infarction, stroke, heart failure, all reduced. In fact, heart failure all by itself was reduced by about 28%, which is kind of an interesting thing. But what overwhelms everything, what gives this study its basically unstoppable power, is what happened to cardiovascular death. Here, right in the bottom line of the study, of the slide, you can see a better than 40% reduction in cardiovascular death when you push the pressure down to around 120, as opposed to just going to the usual less than 140. And this study included people of all ages, all the way up to into the 80s. So this was not just done in younger people, this was done in a very usual middle-aged and elderly population. Huge benefits. In fact, let's look at the primary outcome in the people who were age 75 or more. And this is fascinating to me. I don't think anyone had expected this. But if you look at people age 75 or more, their average age was about 80. These folks that are age 75 or more, their primary outcome was reduced by 34. That's huge in a cardiovascular trial. These 80-year-old people get a 34% reduction in events when you push their systolic pressure down to close to 120. We see a nice result for myocardial infarction. We see a nice trend for stroke. Heart failure moves in the right direction. Everything moves in the right direction. And again, if we look at mortality, a 33% reduction in these older people in all-cause mortality, if you can push their pressures down, their systolic pressures down close to 120. That is enormous. That is very powerful, very compelling, and that is going to be very, very influential in the new guidelines. Now, I have to say something about how blood pressure was measured in sprint. Because I've been talking glibly about 120 looks like it's better than 140. But we have to remember something about how the blood pressures were measured in sprint. They were not measured in the usual way that you or I would use in our own clinic or office when we see a patient. First of all, they only used automated devices, the devices where you put the cuff around an arm, press a button on the device, and the device inflates the cuff, measures the blood pressure. You are not required to do anything else. When these automated devices first came out, they were used, of course, for home blood pressure. People who could afford to buy one could measure their blood pressure at home and didn't have to be taught how to measure the blood pressure in the traditional way. That's all changed now. We all are using automated devices, particularly in clinical trials, and now most of us in our offices and clinics. The old-fashioned sphygmomanometer and stethoscope is soon to be a thing of the past. The automated device is much more accurate, much more reliable, and they get away from bias, and they take us away from differences between an older physician like me versus a young woman who might measure the blood pressure on another occasion. We will hear very different blood pressures in the same patient. Automated devices get rid of all of those variabilities. What they did was they put the cuff on the patient's arm, left the room, let the patient sit there by himself or herself. The device waited for 5 minutes and then measured 3 blood pressures, averaged them out, and the average was the official blood pressure reading. Now, this is an unusual way to measure blood pressure. It's a very good way to measure blood pressure, but it's not always a practical way to measure blood pressure. Obviously, it takes time, it takes space, it takes people. So we have figured out that blood pressures, by this, in quotes, unobserved method, in other words, leaving the patient alone in the room with the device, are about 7 to 10 millimeters of mercury lower than usual office blood pressures. So this is the bottom line, this very bottom bullet. So the achieved systolic pressure of about 121 in Sprint's intensive group, these are the people who did so well, were so well protected from death, corresponds to about 130 millimeters of mercury when you use usual clinical methods. And I'm pretty confident that 130 will be what will be recommended in the new guidelines as the usual target for treatment in hypertension. So not 140 as it was in previous guidelines, and not quite as low as 120 as you might at first think from looking at Sprint, but around 130. And that probably works for people with diabetes, without diabetes, and at all ages. So this is sort of an initial conclusion. The target should be, this is the first bullet here, for most people, non-diabetic, less than 130. But then if we go to the second bullet, for diabetic patients, patients with coronary heart disease, it was technically less than 140, but now with the evidence from Sprint and from other studies makes us realize that 130 is also appropriate. I wouldn't push too aggressively way below 130 in your office or clinic. Trying to get down to 120, maybe in a young person is a good idea, but not in older people. I think 130 is going to be our usual target just across the board. So what about young people? I've been saying how terrific the data are for old people, even people in their 80s, incidentally, frail old people, elderly people who are now walking slowly, losing weight, not doing that well. Their lives were also saved by getting their pressures down into the low 120s, or as we would now say in our own blood pressure system, of getting them down to about 130. But what can we do in the young? Because young people have never been included. Look at this. This is a list of all the major hypertension trials that have been done in the past 20, 25 years. And you can see the average age of the patients in all these trials. And they're all in the 60s, 70s. In fact, in older patients, like HIVET and so forth, the trials were in the 80s, 70s and 80s. Nobody knows anything about the treatment of hypertension in people who are aged less than, let's say, 55. That was the usual minimum age people needed to be to get into these trials. So what do we say and do about people in their 50s, the 40s, the 30s, their 20s, let alone kids? That's another story for another day. But what do we do about young adults? As I just said, we don't have evidence because no patients aged less than 50 were included in these major trials. On the other hand, we do know that young people, even children and adolescents, can have early signs of hypertensive changes. Arterial stiffening, left ventricular hypertrophy is very common in young people, including 12, 14-year-olds, particularly if they have some obesity and particularly if there's a family history of hypertension. This very worrisome arterial disease and heart disease begins at a very young age. Renal findings, we find that changes in renal function in children and adolescents, and certainly in young adults. And we do know from epidemiologic studies in young adults, people in the 20s, 30s, and 40s, that if they have systolic pressure high or diastolic pressure high, or if they have both high, they are at risk of a significant increase in cardiovascular events. So the question again becomes, what do we do about these young people? What sort of blood pressure targets do we choose? Now, a couple of years ago, so-called expert opinion, when a group of experts gets together around a table to make recommendations where perhaps there isn't enough evidence to be definitive. For instance, I was very much part of the writing committee for the American Society of Hypertension International Society of Hypertension Guidelines that came out in 2014. We said for younger people under the age of 50, a target should be 140 over 90, and then we said maybe even lower than that, maybe 130 over 90 if it's tolerated. But now we're saying, because of SPRINT, that 130 over 90 is good for everybody, including people in their 80s. So should we now be thinking that perhaps in people aged less than 40, 120 over 80 should be the right target? And that, in my opinion, is the correct target. I think 120 over 80 should be where we're shooting for most of our patients. And I think we're going to see a big emphasis on that and a big argument that we should be treating young adults to 120 over 80. All right. Let me talk about something a little different just for a moment. I'm hurrying through here now because I want my two colleagues, Dr. Anjan and Dr. Shirish, to have plenty of time for their thoughts. But resistant hypertension, that's become a hot issue because, among other things, the emergence of some non-drug approaches to hypertension, such as renal denervation or carotid body stimulation, have become, if not yet, but they're being studied, and they're being studied for use in people with treatment-resistant hypertension. So people are suddenly saying, well, what exactly is treatment-resistant hypertension? And here are some of the causes of it. These are people who are taking 3 or 4 drugs. You still can't get their blood pressure down to less than 140, or soon we'll be saying you can't get their pressure down to less than 130, or even lower than that. So there's going to be a lot of apparent treatment-resistant hypertension now that we're toughening the guidelines and toughening the targets. White coat hypertension is a big cause of apparent resistant hypertension. People whose pressure is high in the office, but in fact is normal at other times. Poor drug selection. Poor drug compliance, which is huge. The fact that patients don't take their medicines. Secondary hypertension, particularly primary aldosteronism, which apparently is more common than we ever thought. Blood pressure raising drugs that people are taking and not telling us about, for instance, non-steroidal anti-inflammatory drugs or cold remedies. People eating a very high salt diet. I'm sure that resonates with you in India. In fact, my wife and I ate last night in an Indian restaurant, a favorite of ours, close to where we live here in New York. And this morning I had gained 3 pounds. I think that's all salt and water, but I love the meat, the food. We go there regularly. This is a problem you deal with every day, not just once a week. And then you're finally left with true resistance, which I suspect is a rare entity indeed. This is a study from Spain with ambulatory blood pressure monitoring. And I won't go into all the details, simply to point out that, in fact, a third of all these patients who had treatment-resistant hypertension, when you did ambulatory blood pressure monitoring, a third of these patients had perfectly normal blood pressure. So that is a huge thing to think about. If someone is just not doing as well as you think they should be as far as their blood pressure is concerned, if you can't do ambulatory blood pressure monitoring, at least see if you can measure their blood pressure at home, or get a friend or someone who's not a doctor in a comfortable environment to check the pressure someplace else. That will often help you solve the problem. This is a list of the drugs that can raise blood pressure and interfere with treatment. I've already mentioned the non-steroidal anti-inflammatory agents, oral contraceptives, particularly the higher dose estrogen agents, sympathomimetic drugs that we often use for people who have a cold, decongestants, but diet pills, stimulants, which people amazingly still do take, alcohol can interfere, antidepressants, another common cause of interference with blood pressure medicines. So plenty of good reasons to ask questions and get a good history from patients. I like this slide. It's too simple. It's from a good person, Dr. Pimenta in Brisbane in Australia, who showed that switching from a high salt to a low salt diet in people who are not doing well, and this was a 24-hour study with ambulatory monitoring, so it is a reputable way of doing things. You can believe the data. He sees about a 24-point fall switching from high to low salt. I think, frankly, my own experience switching from high salt to low salt hasn't been quite this good, but it's certainly something to do. This is also interesting. These are 4 separate studies from 4 different places: Seattle in the States, Birmingham also in the States, it's Birmingham, Alabama, not Birmingham, England, Oslo in Norway, and Prague in Czechoslovakia, or Czech Republic, I should say. We see that about close to 20% of people with treatment-resistant hypertension had primary aldosteronism. Now, those of you who study secondary hypertension, these patients were not all diagnosed with the most rigorous criteria, but they did have very high levels of plasma aldosterone and low levels of plasma renin activity. So they certainly looked as though they had aldosterone excess. And of course, this is a great incentive to try treatment in these patients who are treatment resistant with spironolactone, which we know works very well. But the big story is compliance. The usual explanation, I would say more than half of all people, is that they're not taking the medicines. They tell you they're taking the medicines. They even go to the drugstore or the chemist and have the prescriptions filled. They take the pills home. They just don't take them very reliably. And here's an example. This was a famous study called DINA hypertension. It happened to be a study of renal denervation in patients who had treatment-resistant hypertension. And the investigators wanted to make absolutely certain that the patients were taking their medicines. Otherwise, it would make it hard to see what the renal denervation was doing. So all the patients were managed at hypertension centers, managed by expert doctors, expert nurses. The doctors and nurses told patients every time they came for a visit the importance of taking medications. They sent reminders to the patients' homes. They spoke to the patients' husbands, the patients' wives, the patients' children, the patients' parents. They were absolutely fanatical about getting the whole family involved and making sure the patient took their medicines. And then they said to the patients, and by the way, we're going to be checking you out because we're going to measure your blood and urine and make sure that we find the drugs that you're supposed to be taking in these samples. Well, this is the result of that absolutely fanatical, intense effort to get perfect compliance. You can see that patients who are fully adherent, who really took everything they were prescribed, were only 50% of the total. About another 25, 30% were taking 1 or 2 drugs, and 20% were taking no drugs at all. After all that incredible, intensive, dedicated effort, still awful compliance. And this is as good as it gets. This is, you can't do better than what these guys were doing. So in the hands of experienced clinicians who are willing to really do everything they can, you can reduce treatment-resistant hypertension, but in the end, we are being thwarted with a very difficult problem dealing with patients who just don't take their medications. Incidentally, it's not just a matter of education. I happened to have, a few years ago, I stopped doing it now, I had a special clinic to see so-called VIPs who came to the medical school. It included a lot of my colleagues, a lot of fellow physicians. And you know something, they were not any better than any of our other patients when it came to following the rules. Benefits of angiotensin receptor blockers, because as I mentioned earlier, they have emerged as very much a primary therapy. Why? Because they work in everybody. Old people, young people. We've got evidence for cardiovascular protection across the board, improvement in heart failure survival, protection against strokes, evidence for prevention of new onset atrial fibrillation. They help to prevent new onset type 2 diabetes. They protect the kidneys. And one other huge thing, they are well tolerated. Here is a study that looks just at that one point. This is a comparison of all the popular drugs: diuretics, beta blockers, alpha blockers, calcium blockers, ACE inhibitors, ARBs. Start at the bottom where it's got diuretic. That is the standard. And diuretics do not do very well. Compared with a diuretic, beta blockers are about 25% more likely to still be getting taken a year after treatment has started. Not a huge improvement, but somewhat better. Alpha blockers are about the same. Calcium channel blockers and lodipine, used as single agents, about 40% more likely than diuretics to be taken. ACE inhibitors, about 70% more likely to be taken. And angiotensin receptor blockers, more than 2 times as likely to be taken. And for no other reason, when you look at these data, knowing that people are much more likely to take the angiotensin blocker and to stick with it over time, that is a huge incentive to make that our core therapy. But let's get to some other good reasons. Heart failure, well, we all know that ACE inhibitors prevent death and heart failure hospitalization in patients with heart failure, and of course I'm talking about low ejection fraction or systolic heart failure. And we can see here that candesartan, one of the angiotensin blockers compared with placebo, achieved a very nice 30% reduction in death and hospitalization. Not a big surprise, but nice to know. New onset atrial fibrillation, staying with the heart for a moment. Compared with atenolol, the beta blocker, losartan, one of the earlier, shorter acting ARBs, perhaps not as good as some of the more recent ones, a 33% reduction in new onset atrial fibrillation. You don't need me to tell you that atrial fibrillation is difficult and frustrating to treat and is increasing in prevalence. We see more and more of it, particularly in people with large hearts, and particularly in patients going into heart failure. Kidney disease. Again, no surprise, you all know this already, angiotensin receptor blockers used in patients with type 2 diabetes and end-stage kidney disease, a big reduction paired with placebo on top of all other sorts of medications to control the blood pressure, ARBs have a significant, roughly 30% reduction in progression to end-stage kidney disease. They do help to keep people off kidney machines or from dying from end-stage kidney disease. This is a study that was done in typical high-risk cardiovascular patients, the same as the HOPE trial. Remember Ramipril, how good that was in high-risk patients? And you all know now that you should give Ramipril or an ACE inhibitor in high-risk cardiovascular patients. The same now has been established for the ARBs. Telmisartan, every bit as good as Ramipril. In fact, in head-to-head studies, identical to Ramipril in preventing stroke, heart attacks, mortality, and other cardiovascular outcomes in high-risk people. So what about the angiotensin receptor blockers? Well, believe it or not, they're not so new anymore. And we've been looking at them for the last 25 years. Losartan was the first to become available, then valsartan, telmisartan followed a little later, olmesartan, and most recently, azilsartan. It's the newest. It was approved in the United States in 2011, and now has become quite popular here in the States. Its normal dose is 40 to 80 milligrams a day. In the States, the FDA prefers that people use the higher dose because they point out that there are no side effects. There are no dose-dependent side effects. In fact, we all know with these ARBs, they're extremely well tolerated. So why wouldn't you use the higher dose to get the maximum effect? It works well. It works quickly. It works well in combination with diuretics and dihydropyridines. There's no need to change the dose in patients who've got kidney disease because it's basically eliminated azilsartan in the liver, not in the kidney. In someone who does have liver disease, you perhaps should cut back to a lower 20 milligram dose. Why is it so powerful? Well, this is the binding of different ARBs to the receptor, to the angiotensin 2-81 receptor. And if looking at these numbers, the lower the number, the more powerful the binding, or the less drug you need in order to inactivate these receptors. And you can see azilsartan is about twice as good as telmisartan, which is excellent, and several times better than some of the other ARBs. It is the strongest binding of all of these agents, which may explain why it is the most powerful. This is its structure, and I'm not going to get into the biochemistry of this. It always amazes me when manufacturers of a drug put up a picture like this, or a chemical formula, and expect clinical physicians to look at this and say, now I understand everything. Frankly, I look at this myself and I really don't understand very much at all, except what I've already told you. There are some very nice ways that it works, quite apart from the usual blocking angiotensin 2. We're looking now at the renin-angiotensin system, and on the left is the way we normally understand it. Angiotensin converting enzyme makes angiotensin 2, it works at the AT1 receptor, and the AT1 receptor causes vasoconstriction and all these bad things, and that's why we block it with an ARB. Now, on the right is a different kind of ACE. It's called ACE2. And instead of giving us the octapeptide, angiotensin 2, it gives us angiotensin 1,7, a peptide with 7 amino acids rather than 8. And it works the exact opposite of the usual angiotensin 2. It causes vasodilation rather than vasoconstriction. It has anti-proliferative properties rather than causing proliferation and accelerating atherosclerosis. So angiotensin 1 to 7 is a good thing. And what's very interesting is that azolsartan increases the availability of angiotensin 1-7. So here on the left, we see 24-hour blood pressure. On the left is baseline or placebo. On the right is giving azolsartan. We see a very nice fall in blood pressure. Well, we already know that. We already know azolsartan reduces pressure very nicely. But look on the right side. That's the fascinating part. These are the levels of angiotensin 1-7. And you can see with placebo on the left, the level is 74. You can see it triples in the presence of azolsartan. Is this why azolsartan is so effective? Could this imply that azolsartan is going to have good cardiovascular protective effects because of the fact that angiotensin 1-7 is so protective against major events? We don't know that yet. No one has done that sort of trial, but it's a fascinating thing to think about. Here is something else. Azolsartan has an effect on salt sensitivity. And if we look on the left, it's just a blood pressure. We're looking at baseline. Then we're looking at candesartan, which is a very good angiotensin receptor blocker. It reduces the pressure from 125 to 111. Azolsartan is even more powerful and gets the pressure down to 103. Well, that's nice, not surprising. We know azolsartan is the most powerful of all the ARBs. But look on the right. What we're looking at there, you see on the vertical axis, FeNA, that's fractional excretion of sodium, but basically the ability of the kidney to eliminate salt. And you can see baseline candesartan doesn't really change it, but a very nice 50% increase in fractional salt excretion using azolsartan. So another fascinating way to think about azolsartan. So why is azolsartan so powerful? Well, first of all, as I already told you, very tight binding to the AT1 receptor gives us very good day-long efficacy. The additional mechanism, the increase in angiotensin 1-7, adds further efficacy and potentially further cardiovascular protection, and also the effect on sodium. The way the kidneys handle sodium and an increase in sodium excretion may also contribute to the blood pressure effect. So this is my very last slide. And again, just to remind you, I just wanted to talk very briefly about our new blood pressure target. We'll know for sure in a few weeks, but I think we're going to be talking a lot about 130 very soon. Hypertension in the young, what can we advise? I think I've mentioned to you for people under the age of 40, maybe even into their 40s, I'd be thinking 120 over 80 most of the time. We talked about treatment-resistant hypertension, the importance of getting patients to take their pills, and finally, the role of the angiotensin receptor blockers and the emergence of azolsartan as an exciting and important new product. So let me stop there and hand it back to my colleagues.
Thank you, Dr. Weber. It was interesting listening to you. Are you able to hear us?
Very well, yes, thank you.
All right, you know, for a long time I always wondered this target of 140 by 90, and to a great extent I thought the JNC guideline 8 did some kind of injustice by sticking to 140-90. But after listening to you today, I'm very encouraged with the thoughts which I had in mind, that it should not be 140, but it should be scaled down to some extent. And I'm very impressed with your thought in younger individuals, taking it further down to 120. It makes a lot of sense to me in my clinical practice when I see these kind of individuals remaining asymptomatic and hitting a lower and lower blood pressure value.
Yeah. Dr. Weber, thank you very much for your excellent and exciting deliberation. To start with, I do entirely agree with you that if you look at a SPRING trial, initially we are very much encouraged to reduce the blood pressure below 120, which was the objective of the study. Though at the end of the day, the average blood pressure, systolic blood pressure was only 121 millimeter of mercury, not below 120. That was the objective of the study, in any case. And you have rightly highlighted the way the blood pressure was recorded. The automated device, no man, silent room, 3 readings, average of that. This reminds me of the ambulatory blood pressure recording. Because if we consider the ambulatory blood pressure recording, daytime cutoff figure is 135 by 85, and anything above that is hypertension. Similarly, in screen trial, if you measure the blood pressure the way it was measured, then that cannot be considered equivalent to 140 by 90 as office recording. And I do entirely agree with you that if you strike a compromise somewhere between 140 and 30, I think 130 should be a good target for a good number of patients. And although this is mainly the non-diabetic patients, and if you look at the ACCORD trial is the only trial before SPIN trial where automated devices were used, not manual recording of the BP. So that diabetic populations also speak for the same truth, that probably 120 would be too low. And that is a very important message. Of course, the future guidelines would ultimately confirm your concept and your ideas and our thought process. But there is no denying the fact that this is something very important at this point of time, considering 130 and not 140, not 120.
Whenever we talk of reduction in stroke, and most of the time beta blockers are criticized that they don't bring down the central aortic pressure to the same extent as ARBs or say calcium blockers. And this is why probably beta blockers don't reduce the stroke incidence. Reduction in the heart rate increases the stroke output and increases the central aortic pressure. So what's your take on that?
Well, I agree that the results with the beta blockers, by and large, have been disappointing as far as stroke is concerned, and even not that overwhelming as far as myocardial infarction is concerned. And you're quite right. Part of the problem is the fact that they do not reduce the central aortic pressure. And as you point out, there's an increase in stroke volume. But more than that, by slowing down the heart rate, the pulse wave, when it hits the periphery and then comes back as a reflected wave, now with a slow heart rate, that reflected wave comes back before the aortic valve closes, so it adds to the systolic pressure. And so we find that beta blockers are not that good for reducing systolic pressure. They're good for reducing diastolic pressure because what they're doing is they are shifting some of the diastolic pressure into systole by allowing the reflected wave to return while systole is still going on. And I think that's part of their problem. They're good diastolic therapy, but not good systolic therapy. On the other hand, I suspect the slowing of the heart rate is one of the reasons they're so beneficial in heart failure, because they're allowing more time in diastole for more effective left ventricular filling.
Do you think central aortic pressure monitoring could be an important thing, especially for future?
Yes, I think the theoretical answer to that question is absolutely. If we had a means for measuring central aortic pressure on a regular basis, that would be a better reading than what we get by the conventional arm method. Having said that, I have sat through many debates, Shirish, on this subject, and the problem is there must be 8 or 10 manufacturers who are making devices that measure central aortic pressure, and they all are different from each other, so that in the end there is no common language. And until someone comes up or some group agrees that it's got to be this one device or it's got to be one method, I think it's theoretically absolutely the right place to go, but we're not there yet. You can do it because you're an interventionalist. You can put a catheter into the into the aorta and get a very precise measurement. And you can also put the same catheter down into the brachial artery and get a very precise measurement. And you can study these things beautifully. But to use non-invasive methods, which of course is what we would have to do in everyday practice, that technology is still waiting. I think it's exciting. I think it's important. We should be there soon, but we're not there yet.
Dr. Weber, in relation to central aortic pressure, do you think that the newer beta blockers, because most of the beta blockers studied were the first generation beta blockers, the newer beta blockers like carvedilol or nebivolol with vasodilating property, are they expected to behave separately? Because there are some small studies which have shown, particularly with nebivolol, that the central aortic pressure is not raised or reduced to a certain extent.
Yeah, that's an excellent point. And I think the answer is yes. And in fact, I am so convinced of that whenever I can, I do prescribe nebivolol for people with hypertension. I think it is probably the best beta blocker. And of course, nebivolol also has that nitric oxide action, which adds to its efficacy. But no, I agree with you completely. The newer ones, and maybe carvedilol as well, seem to be better at reducing central aortic pressure and therefore may have better effects on strokes.
We in India are emotionally quite attached with beta blockers. We don't like to part with beta blockers so strongly and so quickly. So that's why whenever you talk in terms of beta blocker not doing well in hypertension, it takes a little difficulty for us to accept it fully.
It's not only India, Anjan, it's cardiologists, because even here in the States, I would say now 3/4 of doctors, primary care doctors, will use ACE inhibitors, angiotensin receptor blockers to start treatment, but cardiologists, 75% of them still start with beta blockers. Old habits die hard. And of course, cardiologists love beta blockers. You're using atrial fibrillation and heart failure, angina, and so forth. They're your best friends.
Would you just highlight a few points and suggest us what is the importance and what are the particular medications and treatment methods to take care of these few phenomena like early morning surge, deeping and non-deeping, and white coat hypertensions? It has a tremendous impact on the outcome in the treatment of hypertension.
Yes, we're learning a lot using...
And the role of home blood pressure monitoring or ambulatory blood pressure monitoring, particularly to take importance or outline those features.
Yes, you're quite right. What we've learned because of ambulatory blood pressure monitoring is, of course, that the blood pressure at night is lower than during the day, which is appropriate because during the day we're active, we're upright. At night we're lying down and resting and hopefully sleeping. But you point out that some people are so-called non-dippers. They don't have that fall in blood pressure at night, and their prognosis is not as good as in patients who do have that fall at night. And I think what it really means is that it's the nighttime pressure. While we're lying in bed, that's our real fundamental or basic blood pressure, and that is the best predictor of prognosis. So if we had a means for reliably measuring blood pressure at night, I think it would be much better than the pressure we get typically in the office. And you may say, well, that's a nice dream, but how can you achieve it? I think we soon will, because these little devices that are now sold for patients to buy and to use at home will soon have the ability to be programmed in a very simple way So we can ask the patient to put a cuff on when they go to bed, or even a wrist device. I'm not a huge fan of wrist devices, but they're getting better. So if you can put a cuff on, you program the device, it will measure blood pressure once an hour during the night and give us a very reliable nighttime blood pressure for a patient, which is what in the future I suspect we will use to decide who is hypertension and how to adjust our treatments. I think that is coming. I think that is a very important step forward. Maybe a few years yet, but we're getting there.
And to address the non-deepers or early morning surge, I think a particular drug which has a 24 hours coverage, like agilcertain, which is because of its tight binding with the AT1 receptors, the most important factor is its tight binding with AT1 receptors. That is responsible for its longer duration of actions. So either it should be a longer duration of action, or do you recommend a nighttime additional dose of antihypertensive medications for those patients who are you are expecting or apprehending they may have an early morning surge or non-deepers?
Well, I'm even more aggressive than that. In general, I recommend that people take their blood pressure medicines at night. Even, believe it or not, low-dose thiazide diuretics can be taken at night. Once someone has been stabilized on diuretics, there is no immediate or acute effect in terms of the need to urinate. So I do like nighttime dosing, and yes, you're absolutely correct. With something like azilsartan, which is very long-acting, you know you're going to get full 24-hour coverage, so no matter when you take it, you're giving the best possible protection against the morning surge, which I agree. It has been associated with strokes, and we know strokes and even coronary events are more common in the morning hours than at other times of day.
I would just raise that in India, particularly in elderly hypertensive patients, when we are treating with calcium channel blocker, or for that matter any antihypertensives, or even if we are treating them with diuretics, we have certain problems. Like in India, these patients, elderly populations, particularly frail structures, they have a tremendous propensity to get hyponatremia, even with the slowest dose of diuretics. So we don't advise a very strict sodium control or restrictions because of the climates. So hyponatremia becomes a very important issue. Postural hypotension becomes a very important issue, particularly the elderly. And good many a number of them cannot tolerate, although calcium channel blocker is recommended in all the guidelines to be used in above the age of either 60 or 55. But many of our elderly populations cannot tolerate calcium channel blockers because of the fetal edema. So this is something which I find slightly different from what is the situations in other parts of the world. Shiri should probably like to comment on that as well.
Yeah, those are interesting thoughts. And first of all, as far as the diuretics are concerned, I agree with you completely. Most older people anywhere around the world tend to be somewhat dehydrated at the best of times. Somehow as we get older, we lose our thirst drive, and so many older people are dehydrated. You then give them a diuretic, you think this is wonderful, it's working, it's getting the blood pressure down, but then they go out and in very hot climates, and of course India is very much part of that risk, people start losing fluid through sweating, then you're going to get postural hypotension and people are going to faint. I agree with you completely. The other thing too is that it's possible that in India this sort of idiosyncratic hyponatremia that some people get when they take a thiazide may be more common than we see in the States. We certainly see it. We certainly have patients who get hyponatremia when you put them on even a low dose of diuretic. But I understand it is a little more common in India. But you're absolutely correct. When it comes to calcium channel blockers, we don't have a problem in older people. In fact, I really like calcium channel blockers here in the States in older people. because they do work very well, they're well tolerated, and you're right, some people do get edema, ankle edema, with the calcium channel blockers, but it's not a physiologic problem. It's just the way the calcium blockers work. They dilate the arterial circulation, but not the venous circulation. So it's not as though they're retaining fluid. They're not holding on to salt and water. It's just basically a cosmetic. It's an annoyance. If you can't get your shoes on easily, it's very annoying. So I understand all of that. And I think the best way to use a calcium channel blocker, if it's appropriate, is to give it in combination with an angiotensin receptor blocker or an ACE inhibitor, because that minimizes the swelling.
Dr. Weber, talking about the salt restriction, I thought in 2017 we should be telling patients that eat a regular food which your friends are eating, kind of salt restriction, or we allow them a regular standard salt intake.
Yeah, I agree. You know, I was part of a committee that wrote a policy statement on salt. I think we published it in the European Heart Journal a year ago, and we had a very lively debate among ourselves because it was an international group, including a couple of guys from India, it was interesting. The Americans and the Western Europeans on the committee were very much in favor of low-salt diets because that, everyone said, will solve the problem of hypertension for many people. But we were reminded that that does not apply in countries with hot climates, and particularly for people who do manual work or spend a lot of time outdoors or do not have access to cool environments, such as air conditioning, which we take for granted in the United States, in all of our public places and in most of our homes. In India, I noticed from my recent visits that it is universally available now in large shops, in malls and places like that. But I suspect many people in their homes do not yet have air conditioning. And so you're quite right. In India, you would not want to be as aggressive with salt reduction as we are here in the States.
What about dose of azilsartan? You suggested we should be using 80 milligram for majority of the patients, but there are some studies when you are combining AZ with calcium blocker like amlodipine, 40 or 80 doesn't make a big difference. I mean, improving to 80 doesn't give you a big drop in the systolic pressure. So generally, we are trying to combine AZ with only 40 milligrams.
I agree completely with that, Suresh. And as a matter of fact, when the FDA recommended, in fact didn't recommend, they actually stated that the correct dose is 80 milligrams rather than 40 milligrams, I was surprised, and I almost disagreed with them because the difference, as you point out, was only 1 or 2 millimeters of mercury. And in fact, later on, when they approved the combination of azilsartan with a diuretic, then they said 40 milligrams was the maximum dose. So 80, if you use it as a monotherapy, as a drug all by itself, but 40 if you combine it with other drugs, just as you pointed out. And frankly, since I know that in most cases I'm going to be thinking about using a combination, I must admit I usually use 40 milligrams. But it's interesting, the FDA said 80 if it's just the one drug. And I think they're trying to teach everyone a lesson, because one of the reasons that patients don't get good results when you treat the hypertension is doctors don't always give a high enough dose. If you go to some of the older ACE inhibitors, like enalapril or lisinopril, doctors will start on 5 milligrams a day, maybe go to 10 milligrams a day. But the best results are with 40 milligrams a day, and there's no more side effects with 40 milligrams than with 5 milligrams. So why not use 40 and get the best possible result? And that was the thinking they now try to apply to azilsartan. But I agree with you. The difference between 40 and 80 is trivial, and 40 is, in my opinion, is just fine.
Yeah, that was an interesting study of lisinopril using 30 and 10 and finding that 30 is superior. And there is a feeling amongst many of the cardiologists that the ARB should be used in the highest dose of ARB for when you are using the single medications. But I do agree with you and Dr. Shirishma that Thiramat, that in our country particularly, if we use 40 milligram dose of azilsartan and combine it with diuretics or calcium channel blockers, and if it serves the purpose, and that will go a long way in reducing the cost of the medications as well.
Yes.
Because 80 milligram is quite costly. From that point of view, I think a combination of 40 with diuretics should be have a better compliance with the patients from financial point of view as well.
Yes. In India, what is when you decide you want to use a diuretic in combination with an ARB or an ACE, is hydrochlorothiazide still the popular one, or is there some interest now in trying chlorthalidone or some of the other so-called thiazide-like agents?
The two issues are important issues because
we are clearly moving.
If you look at the different trials, like ALATS trials and other trials and HOPE trials, we find that chlorthalidone is used more frequently in the recent trials. So we would prefer chlorthalidone, but we should keep in mind in Indians that 6.25 chlorthalidone is almost equivalent to 12.5 milligram of hydrochlorothiazide.
Yes.
Both in efficacy as well as in reducing the electrolytes.
Yes.
So we like to use chlorthalidone, taking care not to go the dose, to keep it high, keep it as low as possible, either 6.25 or at the best 12.5, not 25 as it is often we use in hydrochlorothiazides.
That's an interesting point. Suresh, you had a thought about that too?
Shirish, Dr. Weber would seek your opinion on these diuretics about chlorthalidone or hydrochlorothiazides, particularly in relation to doses.
Yeah, I think we are all moving towards chlorthalidone, more and more of chlorthalidone, though hyponatremia in India seems to be a problem. How about spironolactone? I think this is something which is gaining more and more popularity, especially amongst the resistant kind of blood pressure patients. Then even going a step further, epinephrine, a little bit more expensive, but that is also finding some inroads. Dr. Weber, you think this is a good approach?
Yes, it is, and the data are quite strong. The problem is spironolactone is not liked very much by patients. And so there's a famous study, I sort of briefly went past it as one of the examples of high aldosterone being a possible cause of treatment resistance in hypertension. And in the Prague study, they actually used spironolactone. And after a couple of months, said, we've got wonderful results. The pressures have come down dramatically. But when they did the one-year follow-up, the news was not so good because most of the patients were refusing to take the spironolactone. I think only about 30% of patients could still be persuaded to keep taking it. Now, you mentioned eplerenone, which is a more friendly drug, but here in the States, even though it's a generic drug, it's very expensive. It's very expensive. I don't know if it's less expensive in India, but I'm told it's expensive because it's difficult to manufacture. It's not a simple process. And so I think eplerenone is used even here, not as much as it should be. And I'm hoping there may be some new drugs of that type that might become available over the next few years that will be more affordable. and better tolerated.
Dr. Weber, do you believe that you had pointed out, given the list of the apparent causes of so-called resistant hypertension, if you take away those factors like drug interactions, poor compliance, poor lifestyles, if you take that away, and even then, we get a good number of patients having hyperaldosteronism as a cause of resistant hypertension, particularly in the females, obese females. And these patients do well, very much, dramatically improvement in blood pressure with mineralocorticoid receptors blocker or aldosterone, whatever it is. So do you think as time has come, or we would soon come to situations where we will define resistant hypertension as one who is not responding to 3 drugs, including one mineralocorticoid, rather than including one as diuretic?
That's a very provocative question and a very good one. Because you're quite right. You should not call someone resistant hypertension until you've excluded a plausible explanation for it. And you're quite right. If you can give them spironolactone and the pressure is still high, then you can be probably more comfortable that you have achieved a legitimate diagnosis of treatment-resistant hypertension. So yes, or you could change your argument slightly and say, use the usual 3 drugs, let's say the ARB plus the CCB plus the thiazide. Now you're suspicious, now you give the 4th drug, which is spironolactone, and if you still don't get the pressure down, then you declare this is true treatment resistance. As long, of course, as you can be sure the patient was taking any of those drugs.
That is the most important factor that we should keep that in mind.
Yeah.
And when we are talking about resistant hypertension, I find in India, actually some secondary hypertension apparently behave as resistant hypertension. One is that an elderly man around the age of 60 years, whose blood pressure was controlled, and he has suddenly become decontrolled for last, say, 6 months, although he's taking all the medicines and there is no drug interactions. And one of the commonest cause I find in the male person, particularly the renal artery stenosis, atherosclerotic renal artery stenosis, sudden resistant hypertension developing who was on control of blood pressure, elderly male person. So that is a very important cause of so-called resistant. And another important cause I find, which is true everywhere probably, is the obstructive sleep apnea. Obstructive sleep apnea syndrome. So these are 2 apparent very important causes of resistant hypertension. More often we come across them, which is reported in literature.
You know, I'm glad you mentioned obstructive sleep apnea, that is an important cause, and it's definitely something to be asked about and considered. And this business with the renal artery stenosis, we see that here as well, but I understand that Indian men in particular, more so than women, but Indian men are very susceptible to advanced atherosclerosis, premature coronary disease, and of course renal artery stenosis is really a member of that family of pathologic changes. And as far as I know, the explanation for this high vulnerability to this premature atherosclerotic disease is not well understood.
Yeah, that's true.
But we see it here in the United States too, that men of Indian origin are very susceptible to early coronary disease. Well, as interventionalists, I'm sure you must see men in their 30s and 40s in whom you have to do acute interventions.
And about your NG17, the second mechanism of agilsatin, working through NG17 through mast receptors. Is it only with agilsatin, or you get the same thing with olmesartan to a certain extent?
You might get it to a small extent, and if I recall on that slide with, I think it was candesartan was the comparator, there was a small increase in angiotensin 127. So I suspect it may be common to most of the angiotensin receptor blockers, but the extent to which it happens with azacitidine does seem to be quite remarkable.
And this NG17 not only causes further reduction of blood pressure by vasodilatations, It has effect on insulin resistance. It has effects on antioxidant effect. So it seems that NG17 has a pleiotropic effect, like or metabolic effect. So we can consider azilsartan as a metabolic sartan from that point of view, other than pipergamma efficacy.
That's a very good point. That's an excellent point. Yeah, the unfortunate thing with azilsartan is that it's one of the last of the angiotensin receptor blockers to be developed. And so the incentive to do major outcomes trials, or the commercial reality of doing outcomes trials, is become quite difficult. So I wish we could test that out, because I suspect what you're saying is very interesting and very important. And it could be that azilsartan isn't just the best for blood pressure lowering, it may be the best for overall cardiovascular protection.
So what do you think about...
We have time, or we close? Dr. Weber, thanks for being with us.
How many minutes time we have with us? Shiramat like to have some comments. 5 minutes time we are left.
Actually, I was wondering role of beta blockers in hypertension. Do we strongly feel that? I mean, I generally use it for young individuals. Most of them have a high sympathetic drive. You see them; they have just one subset where I still feel an important role for beta blocker. Dr. Webb, agree on that?
Yes, I do, and we do see young people who have fast heart rates, which is a reasonably good surrogate for excess sympathetic activity, and they do respond very well to beta blockers. And they clearly have a different kind of hypertension, but in such patients, there's no question the beta blocker is the treatment of choice. And there are other times, too, when a beta blocker, for instance, there are many people whose anxiety and other symptoms can be improved with beta blockers. And so beta blockers are always somewhere in your thoughts in many patients.
It's very difficult to get rid of beta blocker from our thought process.
Yes.
And particularly so, we have so many cases of ischemic heart disease in India at different age groups, and also LV dysfunctions because of ischemic heart disease or something like that. So these two becomes a very important, compelling indications: heart failure and ischemic heart disease along with hypertension. And the one study like from Canada that had shown that most of the stroke efficacy of beta blockers not having good effect on strokes were seen in the elderly populations, particularly above the age of 65 or 70. Before that, below that, I think in India still we have more cardiac problems than stroke problems. If we can keep the blood pressure controlled, I mean figure-wise, then the central aortic pressures causing greater incidence of stroke, we don't have full data as yet, particularly the younger or 50, 60 years old age group patients. So that is why our concept is more, we are more preoccupied with cardiac problems rather than stroke. We like to be happy with so far as stroke is concerned by controlling the systolic blood pressure only. But probably that is not right, but then that is what is the mindset is ours.
No, and totally understand that, yes. Yeah, and you make a very good point. We talk about the absence of evidence to show the benefits of beta blockers in hypertension, but the point I made earlier holds, and you've really put much more power behind it. We just don't know. Beta blockers might be maybe the absolute drugs of choice for people in their 20s and 30s and 40s. That's something we need to learn more about.
Dr. Weber, what do you think is going to be the future of renal denervation therapy? It's going to come back, or it's a kind of a low-key advice?
Well, we just had a paper published in the Lancet called the SPYRAL trial, SPYRAL, which is the name of a catheter used for renal denervation, which for the first time in a properly controlled, randomized clinical trial showed that there was a significant benefit to renal denervation. Now, it's only a small study, and it's the first such study, but it's given everybody a boost of interest again in renal denervation, and so there will be a whole group of new studies. In fact, some of them are already underway in renal denervation. So it's definitely not a done deal yet. We certainly are not sure where it's heading. But if for the moment, we're all think there's enough evidence to continue the research, and we'll see what happens. I think it could be a very useful technique for proper, well-selected patients.
It was I think it was a fantastic lecture by you, and we all appreciate it, and I'm sure all of us have benefited. And we have gone into the nitty-gritties of hypertension, both in terms of its definitions, its newer issues, particularly in terms of treatment and targets, which are the most important dynamic process or the dynamic facets of the subject of hypertension. So we are very much, what should I say, grateful to you for being with us for such a long time and giving us all the inputs.
Well, thank you.
Thank you, Doctor. It would be interesting to have you back after the AHA meeting. Whatever you predicted, it would be very good to collate.
Yeah, thank you. No, I will look forward to reporting back and continuing the discussion as soon as we get some more information. Thank you, Suresh.
Okay, thank you very much.